I welcome everybody to the second Women in Intensive Care ANZICS traditional custodians of the land in which we gather today, and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. Women in Intensive Care, with these webinars, we aim to explore several important topics relating to gender equity in intensive care medicine, such as leadership, representation, culture, mentoring and research, as well as provide general educational sessions related to intensive care practice. This research-themed webinar will feature Professors Imogen Mitchell and Carol Hodgson, discussing respectively their work on gender equity in ICU and long-term outcomes for ICU patients. Achieving gender equity in the intensive care workplace is increasingly recognised as an important issue facing the critical care community, including the research community. Prominent journals such as The Lancet and NEJM have published widely on this matter, including original research, frequent editorials, and the dedication of entire issues to the theme of gender equity. Professor Imogen Mitchell will be presenting her research on the topic using a local lens. Professor Mitchell is the Dean of Medicine at ANU Medical School, Senior Medical Advisor to the Australian Commission on Safety and Quality, and a Senior Intensive Care Specialist at the Canberra Hospital. Thank you, Dr. Mitchell.
Thanks, Vanessa, and good afternoon to everyone. I'd also like to acknowledge the traditional custodians of the land we're all meeting on. I'm actually meeting on the land of the Ngunnawal people, and acknowledge and respect their continuing culture and connections to the land, and also acknowledge and welcome other Aboriginal Torres Strait Islander peoples who may be attending today's meeting. So what I'd like to do is hopefully share my screen and give you an overview really of what I see is happening with, I guess, gender in particular in the intensive care environment. So perhaps just to correct Vanessa, I used to be the Dean of Medicine at the ANU. I'm now the Executive Director of Research and Academic Partnerships. And I've also had a reasonable role in the ACT COVID response. So look forward to hearing what Carol has to say today. So I became interested in women in intensive care. And for these slides, I also would like to thank Donna Goldsmith from the ANZICS CTG, who's given me quite a bit of data, and also Daniel and Jana at the College of Intensive Care Medicine, and also Sandra today, and Lucy previously, and Naomi, whose work I will also present. Now, I don't want you to sort of necessarily see me as an ardent feminist, although I did have a bit of a conversion a few years ago, and I'll talk about that. But it's really for things to think about and how might we move forward in the intensive care world. So my transformation came in thinking about women in intensive care when I was very lucky to be awarded the Harkness Fellowship by the Commonwealth Fund, which is based in New York City. And I was able to go to the School of Public Health at Johns Hopkins, and that's Johns Hopkins Hospital on the slide. And what happened was I was actually given too much time to think, and suddenly started to realize that as I was getting older, and as a female intensive care specialist, I really should start to put more thought as to how we could attract more women into the intensive care environment. And suddenly when I got back in 2014, I had reasonable conversations with the president of the College of Intensive Care Medicine to see how we could actually make a difference. And I guess at that point, he wasn't particularly, I guess, supportive that the college could actually make a difference for us. So what I'm going to do today is try and present to you some facts, potentially interpreting the facts, why we're seeing the facts that we are, is there hope for change, and are there some potential solutions? So the facts as we see it today is, if you see the top line, that's the trainees in intensive care who are women, still under 50%, but now we've almost reached 40% in 2020. But I think what you'll see is that the number of fellows of intensive care is really sort of stuck in the sort of low 20s. I think it has hit 25% now. And you'll see that the orange line is the difference between the two. And I think this is really concerning for me. And I didn't know these data until last week. I thought they might be better than they are. But what we see is that those two lines are not coming closer together. And indeed, of the last few years, 3 or 4 years, there really has been no significant impact in terms of the number of fellows going up in terms of women, and obviously in keeping with the number of trainees going up. So we've plateaued in terms of where we're seeing women in intensive care. Now, it is no different to other disciplines. This is fairly old data now. I couldn't actually find any more recent data, but we sit with the lower percentages with cardiology, orthopedic surgery, general surgery. Probably less so these days in emergency medicine because it's 2015 data, and probably less so in anesthesia. But if you look around, orthopedics has made a huge push for women in orthopedics, and I'm just starting to wonder whether we also should be operating in the same plane. You will see, however, that the ANZICS board, which used to be all male, now does actually have 28% of women being represented on the board. There is a larger proportion on the College of Intensive Care Medicine board. And if we look at the presidents around the country, then you'll see that at least nearly 50% of the leaders of various colleges are women. And in fact, this has probably just gone up today because I think the presidency of the emergency medicine is now Claire Skinner, so that does add one more. But as we know, the leader being female doesn't necessarily mean that the rest of them behind are actually women. And in fact, if you look at this photograph of the new Premier of New South Wales, what was striking about this photograph is that we probably thought that there were more women in Gladys's cabinet. But in fact, once you take her away, you actually don't see many women at all. In fact, there are no women in this picture. And in of itself, all blokes, all middle-aged, it seems, and I think mostly white, and not too many women in sight there at a bar. So being a leader, being female, doesn't necessarily represent what's behind you. We will see that in the United States is no different. If you look at the diamond blue graph, you'll see this is pulmonary disease and critical care medicine. So not quite the same as intensive care, but it also sits around sort of 20, 25%, or maybe just as much as 30, but very similar in terms of the number of fellows that we have in intensive care, sorry. If you go to France, again, if you look at the younger age group, there is an increasing percentage of women doing intensive care or anesthesia. But again, if you look to see how many women are being represented at the higher decision-making level, you'll see the middle graph where the black columns are, that's the women's. And you can see that they're really represented very infrequently, probably a little more so on scientific committees, but not in the leadership positions. And indeed, Bala Venkatesh led a study across the world looking at women in intensive care in 2018, and sort of finalized by saying, you know, despite limited information globally, available data suggests that females are underrepresented in training programs, special positions, academic faculty, and leadership roles in intensive care. That, unfortunately, is not surprisingly data that we are all too familiar with. But again, if you look at the academic world and the number of women, as you go up the totem pole, you will see that the number of women who are occupying professor or associate professor position sits very similar to what we would see in terms of the fellows of intensive care. So around sort of the low 30s, and I suspect if you look at the professor level, it is less than 30%. So very, very similar to what we see within the intensive care unit. So more junior positions as opposed to senior positions in the academic world. If you then look at the academic world in the intensive care unit, you will see that this is a reasonably recent publication. The top graph shows you the first author, so there's someone who's leading and doing the research, and then the second dotted line is the senior author, so who's actually, I guess, head of the department, or leading from a leadership point of view, the research. You can see that it sort of sits between 20% and 30% of all critical care papers that have been investigated in the world. If you look at the high size, again, in the critical care arena, you'll see that there are very few, which are the orange bars, that are being represented in the world in terms of publications. It was noted that if you had a female first author, that nearly doubled when the senior author was female rather than male. So suggesting that if you had female mentorship, then you're more likely to encourage women to actually join you in the publication and join doing the research. So there may be a lesson in that for us. If you then look at Naomi Yarwood's work that was done looking at papers and publications coming out of the clinical trials group between 1996 and 2016, she looked at first authors and last authors of all the CTG trials that have then led to publications, 137 in total. You can see that the predominant authors in terms of first author are male, so 2/3 and only about 1/4 are women, and the same really is reflected in the last authorship as well. If you look at the NHMRC funded study, so as we all know, the ANZICS CTG is incredibly successful in terms of getting huge trials done, very famous publications, the New England Journal, be it Lancet or other Q1 journals. If you look at the management committees of these studies, 37% of are women in terms of the membership. And then if you look at the NHMRC funded trials in terms of publications, of which at that time there were 22, the first authorship was 14%. So even lower when you got to the really high-end journals. And then if we look at the speakers of the CTG, you can see that over time there has certainly been an increasing number of women who are being represented as the speakers, both as I guess total speakers and also as the conveners. You will see that the number of women as international speakers, which is in red, is reasonably low. I think what I would like to see teased out is, even though we have a wonderful array of female speakers, I wonder how many of those are actually medical practitioners. So why is this the case? And I've shared this story before, is that we know that very early on we get socialized in thinking, and I am as guilty as the next door person probably of my vintage, that when someone starts to mention professor or doctor, I probably start thinking men, and I obviously have been socialized into that thinking. I try very hard each time to not do that, but that does happen. Certainly in the UK, if you look at the gender stereotyping, when it starts as the ages between 5 and 7, and you may have seen this YouTube clip, but this is the class of 5-year-old children that are asked to draw firefighters, surgeons and fighter pilots. And of the 61 pictures that were drawn by these children, these are in disciplines which are have been traditionally male. Only 5 out of the 61 pictures, 5 out of the 66 pictures were actually drawn as women. And again, I've told this story before, much to the embarrassment of my own child, who has in fact grown up all her life with a female intensive care doctor. And one evening I asked her as I was going out, could she draw me an intensive care doctor? And this is the picture that she drew. And to my mind, that looks very much like a man. Even though she had lived all her life with a female intensive care doctor, she drew an intensive care doctor as a man. She subsequently is furious that I didn't mention what I wanted this for. I'm sure will be embarrassed to the end of her time that she did this, but this is how she's been socialized, which is disappointing. So what are the potential barriers? Why don't we see more fellows who are women who are in the intensive care unit? Well, you could argue that it's, potentially it's not an attractive discipline for women. They don't have many female role models or mentors. If you think about it, every time that someone comes into the intensive care unit, they're seeing people working very hard all the time. Now, what they don't see is the non-clinical time as a consultant, or indeed the days off, but they do see people working very hard at the time that they're at work. There is potentially a lack of flexibility of the hours. There's also a lack of portability of entitlements as juniors. And you could argue that intensive care is perceived as a very masculine discipline with lots of gadgets and machinery, rather than thinking about, well, actually, that's only part of the story. And in fact, it is much more about people and relationships and conversations and communication and teamwork. And unfortunately, still to this day, I am hearing women who are actively dissuaded by male colleagues from entering into the intensive care environment, which I think is, very tragic when we're talking about 2021. In terms of employing women, there may be an overt gender bias, because often you'll find that a lot of the appointment panels are dominated by men, and there may also be unconscious bias, so you don't realize this is happening to you. So I guess when you describe unconscious bias, it's triggered by our brain making quick judgments and assessments of people and situations influenced by our own background, cultural environment, and personal experiences. You don't actually know that you're somehow subtly making these assumptions. But what then happens is that impacts recruitment, it impacts promotion if you're in the academic world. I suspect it also impacts speaker requests, and I certainly probably have fallen foul of that, and research collaborations as well. Now, the difficulty with the work environment is that the training for intensive care occurs probably at the peak time to have children, and we probably still do have a situation where women are the main carer. Now, this may hopefully be increasingly changing, but it certainly hasn't been true over the last 1 or 2 decades. And there are long shifts, so it's very hard to manage children whilst you're training unless you have a very supportive partner or a structure where your children can be supported. I do believe that the hours are still relatively inflexible. It's quite hard to find part-time jobs without job sharing, and we're trying to look and change that. And it's very difficult to be offered a position when you're about to go onto parental leave. And also equally bad is that there's no guarantee that that position may be there when you get back. Sadly, I think we still have issues with sexual harassment and bullying, although we know from external pressures this is meant to be diminishing. And we're all thinking, well, you're going to get there by merit, but unfortunately, I'm not completely convinced that that is actually going to happen. But are there signs of change? Well, there are signs of change in as much as we know that the number of women going into medicine and graduating in medicine is around 50%, but it has been that for a number of decades. So I guess whilst it's good, it's still not being translated into the number of fellows in intensive care. As I said to you earlier, the number of women who are trainees is sitting around 40% last year. But the issue is, as I say, that I don't think is really necessarily translating into the number of fellows. And if anything, I think we've sort of slowed the progression over the last 3 or 4 years of the translation to fellowship and the so-called leaky pipeline. Why is that occurring? Why are women dropping out? And what is it we can do to support them continuing on so that we actually do have a diverse group of intensive care specialists? Progression, potentially, I do recall sitting in a European Society meeting in Brussels in March in 2018. And I think 2 things came to my mind. One is I can't believe it took me 3 days to work out that I actually hadn't seen a female speaker. That depressed me that I wasn't recognizing that. But when I went to look at the number of people on the scientific advisory panel, of which there are at least 20, not one of them was a woman. Now, I'm pleased to say there's been progress. There's now 24% of the scientific advisors who are women, and that's great to see, but it's probably still not good enough. So at least it is progress, but still very slow. What's the need and signals for change? Well, I would argue that we're missing out on the brightest and the best, so it's good to have those people at the bedside of intensive care. Nominally, females are academically superior when they leave school and also when they graduate from university. So why is it that we're missing out on the brightest and the best at the bedside? We do probably need to match our population in terms of the patients that we see, in terms of diversity. And we know that we have better diversity of teams, we're better at collaboration, and we're better able to see things differently across the group. So hopefully resolve some issues more readily. And as I said to you before, I think intensive care needs to be sold not just about gadgets and machines. It needs a wide range of skills, and therefore you need a wide range of people. So potential solutions, and I think this is something that I'm now starting to realise that there needs to be more activity. And I think the Women Intensive Care Group has been fantastic, but we probably need more. We have still more to do. So marketing strategies, whether it be to medical students, providing graduates with opportunities for mentorship, both for men and women. I think we need to look deliberately at mentorship programs and potentially sponsorship of female trainees and specialists. I think we need to deliberately support people through their training program, but also in terms of supporting research as well, actively seeking out to support them. And whether, we continue to give grants who have research groups that exclude women or have too low a percentage. So we do need to actively look at that. I personally think the college does have a role, and whether there needs to be a position statement on gender equity amongst fellows and trainees. And I guess we've certainly moved steps towards that, and in fact completed a number of steps forward in that regard. Whether we need to look at a more robust code of conduct for professional behaviour, including gender discrimination and sexual harassment. And I think we do need to look closely at how we manage sexual harassment so that we maximally protect our predominantly female trainees who get harassed. And whether we need to look at the accreditation process such that there need to be sponsorship programs for trainees and specialists, particularly looking at women, that the working patterns for trainees and fellows need to be available so that they're part-time positions that don't look at necessary job sharing. We need parental leave without penalty, and hopefully moves are afoot to actually make that happen. And I guess adopting some of the academic world philosophy that the 50-50, if not why not questions, the shortlisting of jobs, interview panels and consultant staff, and that the interview panels to have an unconscious bias observer, which does happen in other environments. So I do think we need to continue to look at the data. I'm not completely convinced these data are looked at regularly, both at the college level, but also at the regional level. I don't know whether we're still looking at the female speakers of the College of Intensive Care Medicine, both domestically and internationally, and whether we're actively looking at their board percentages, both at the college level, but also at the regional committees, and also at the examiners and accreditation teams. It's not clear to me that those data are being tracked. So in summary, and I think this is a sort of sad slide because I don't think we've really moved on necessarily in the last 3 or 4 years. I mean, there's certainly been some positive steps, but we're still seeing very low female fellows. And to some extent, that's been mirrored by board membership proportion, examiners and supervisors of training. And I think we do need to really look at the leaky pipeline. I'm concerned that that line has plateaued, but it's a really complex issue. But the first thing, of course, is to acknowledge it. Next thing is to do something about it. And then the third step, of course, is to see some change. And on that note, I shall finish.
Thank you so much, Professor Mitchell. That was a really illuminating talk. I just want to open the chat now to any participants who have any questions. You can write them in the online chat and we'll see if we can answer them. If not, we can also answer questions at the end after Professor Carroll's given her talk as well. Yeah. No problem. What we'll do is just so we can, people can save up their questions for the very end for both Professor Mitchell and Hodgson. What we'll do is we'll move on to Carol's talk and then, oh, sorry, there are a few questions here. So Di Stevens, how do we engage the men in this is the question. I don't know, Imogen, if you've got an answer.
Great question, Di. You're probably able to answer this better than I can. Well, I guess I might see it in a couple of ways. One is your data are always powerful in terms of we can persuade there is an issue. I think thereafter we need to look to respected male colleagues, respected that we respect them as women, but also that they're respected by their male colleagues. And I think we probably need to engage them to help us change the way either we're recruiting trainees, that we need to help people understand that intensive care is not such a terrible environment. It's a great discipline to do. It can give you loads of opportunities, and I think that may be a step forward.
A few more questions here from Michaela Kartner. Has there been a survey of why trainees are quitting?
Yeah, look, that's a great question, and I think for myself, I think for me, and maybe Sandra might be able to answer this better than I can, do we have data to suggest why trainees are actually leaving? Do we know that they're leaving? Sandra, do you have any thoughts?
I don't think we actually have any hard data, or the college doesn't have any hard data. And I think part of it is because of the way that the college training program has been structured traditionally, in that you could, co-opt from RACP, RACS or ANZCA. And so training numbers were huge, and then you'd have masses of people dropping out anyway. So I think there needs to be some dedicated research in the area targeting people who have prospectively, thought about a career in intensive care medicine and then left. But that's going to be difficult because you're not really going to know the denominator of that survey. So that, how do you capture those people? Who are you going to target? It's going to have to be kind of HMO level. So probably some serious research and some structured interviews and some focus groups would probably be the best way to approach, a pool of potential trainees who have dropped out of intensive care medicine for one reason or another. Or perhaps even asking the college to for trainees who are no longer engaged with the college, to kind of record the dropout rates and to perhaps, offer them an exit interview as to why they're actually leaving. Because I think anecdotally we could all say, well, we kind of lose them to anesthetics when they get sick of all the night shifts and the long hours and the perceived lack of flexibility and the kind of toxic masculinity that can come with a junior registrar job in intensive care medicine. So I think it's going to be really useful to capture that, but it's just going to be really hard to capture that in a really robust manner, if that makes sense.
Yeah, and I guess having just seen the data, I was actually quite shocked. I thought we had in fact made some inroads, but and I know there's a lag time, but I just think that the fact that the difference is plateaued really is a worry. If you want to keep on answering questions, what is a deliberate sponsorship program? Good question. I guess how I've seen it is, and I'm just not convinced it can happen outside of your own intensive care. I know myself, I was part of a research group, but because I wasn't in the same city, I don't think I got the same opportunities. So I think sponsorship to me is that you have an identified individual that you're actually actively sponsoring, and that means that you really are supporting them in terms of writing papers, that they're the first author, that they deliberately go to the conference, you sponsor them through that. That you help them with their PhD, and I guess that's more in the academic world. But I think that's certainly, it's being very supportive in a deliberate kind of way. I think it's more deliberate than mentorship. I think mentorship sort of, for me, is a bit vague. To me, it's and I guess a good mentor probably also would sponsor people as well. Has there been any comparison between adult and pediatric intensive care trainees and fellows? I actually don't know the answer to that question. Does anyone else know the answer to that question? Sandra, do you know? Vanessa? Someone? No. It's a good question. We could look that. College could do this as a quality assurance activity. Yep, that sounds great. Thanks, Di. Yes. Okay, Celia. The thing I found was yep. Yeah, well, that's a good point. Celia, I think you have a very good point. Is do we deliberately not want to go into these situations, whether it be a board member or in the academic CTG environment, because they're predominantly men? I don't know, and maybe some people do feel like that. I do think it is more helpful to have more women around the table. I find it a better environment.
I think it also requires a huge time commitment. And historically as well, lots of travel to Victoria, 3-4 times a year for board meetings. And I think due to the additional external pressures that women are facing, particularly with the COVID pandemic, caring roles, there may be, additional barriers in that there's just no time to actually engage in these really kind of quite labour-intensive volunteer endeavours, when we're still disproportionately in caring roles as well as our clinical roles. Yeah, so I think that could also serve as a barrier for women, serving on these.
Yeah, and I think, I was just thinking about this morning in terms of travelling overseas. Is that, if you do travel overseas, you actually have to have planned your child's, meals for the next, 8 days or whatever, which I'm sure I'm probably the only one who has to do that. But I suspect, I do remember Sandra Peake talking about how mentally she has to, was having to manage her children, even though she wasn't there, so to speak. So I think it is an ongoing shift. How many men are logged on? I don't know. Do we know who's logged on? I think flexibility, it's obviously an issue, and it has to be at the unit level, and it is obviously difficult in smaller departments. But I don't know, if we keep saying flexibility is impossible, then it'll still keep on being impossible. I do think we need to look at being more flexible, and this is someone who's old and very rigid. Okay, let's move to Carol's talk.
Perfect. Thanks so much, Imogen. It makes me really happy as well that there is so much discussion that's been generated by your talk. So clearly it's an issue that's on many people's minds. Have you ever wondered what happens after your patients leave the intensive care unit and what becomes of the ICU survivors? Only recently has the spotlight begun to shine on this important issue, which our second speaker, Professor Carol Hodgson, will discuss. Professor Hodgson is head of the Division of Clinical Trials and Cohort Studies in the School of Public Health and Preventative Medicine, and is a Deputy Director of the Australia and New Zealand Intensive Care Research Centre in Monash. She's a specialist physiotherapist in the intensive care unit at the Alfred Hospital in Melbourne. Thanks so much, Carol.
Thanks so much, Vanessa, and Imogen, great talk. I really enjoyed listening to that. And I think that while you can see that there are shortages of female intensive care staff, there's also, in my opinion, shortage of females in leadership, full stop. And I agree with you that often what we see is the allied health and nursing females up and talking at some of our major meetings. And it's a real pity that there aren't more female medical staff. So if anybody's interested in academia, please do let me know, because I'm very interested in mentoring some of the female medical staff. So I've been asked to speak about disability and survivors in critical illness. And I think you can probably imagine, yes, partly as a female, but also as a non-medical person, when you start to do research in intensive care, you really need to have a point of difference. I think that's really important for anybody who wants a leadership position. Well, not just a leadership position, but just to carve out an area that's perhaps important to you, or that you can start to become an expert in. And I had some great mentors, mostly male mentors too, and they really did encourage me to look at functional recovery. And I think that you'll probably agree with the physiotherapy background, that sits really nicely. One of the things I started to do when I worked in ICU was, and this was even before my academic career as a clinician, I often wondered that, you know, as the patient survived and they left ICU, was that going to be enough? You know, what was their recovery going to be like? And there are a couple of patients that were critical in my thinking about this, and they were young and they were incredibly sick, and they were in our intensive care unit. You know, 3 of them were female, 1 of them was male. They were in our ICU for over a month. 1 was head injured, 1 had a terrible lung infection and was on ECMO for weeks and weeks. And they all looked so terrible and cachectic and, you know, like they really wouldn't recover. And I wanted to know, would that be enough? And then when I started working in clinical trials, you know, the question was raised again, and I wanted to just show this as a case example of where my thinking was. So my immediate director, Jamie Cooper, led the decompressive craniectomy trial, and as you know, it was in TBI. And if you looked at the early surrogate markers, they showed a decrease in intracranial, decompressive craniectomy showed a decrease in intracranial pressure, decreased in therapies for intracranial pressure, and decreased ICU length of stay. And if Jamie had just picked mortality as the primary outcome, you would have thought that there was no difference between decompressive craniectomy and standard care. And the neurosurgeons would have continued to perform decompressive craniectomy. But when we looked at morbidity, not just mortality, you can see that there was significant morbidity associated with decompressive craniectomy, such that you know, decompressive craniectomy actually had a harmful effect on patients at 6 months and at 12 months. So now we're looking out to 5 years, and this really led my thinking into, you know, we really do need to look at long-term outcomes. So I'm just going to talk you through how I have structured my career, trying to learn from national and international practice, trying to identify who's at risk, and then looking at some of the interventions that might improve recovery. So this is a conceptual model of the World Health Organization, where you have a physical, a mental and a cognitive baseline status, which is interrupted with an acute illness. And you can see that that leads to sort of organ impairment, functional and activity limitation, some sort of disability, and potentially reduced quality of life. And Margaret Herridge showed us a long time ago now, a decade ago, that if you looked out to 5 years in survivors of severe ARDS, and this was actually quite a young cohort, that they never recovered back to their previous level of functioning. So their survival dropped off over 5 years. The distance they're able to walk never came back to normal. And their health-related quality of life measured with the SF-36 was lower than normal, particularly in the physical component score, more so than the mental component score. And not just that, she went on to show that those survivors continued to cost a significant amount of money and were more often readmitted and required healthcare services. But this was one of the studies that really informed how I've thought about long-term outcomes. And it's again from a long time ago now. It's from Bonato, published in the Blue Journal also a decade ago. And the lovely thing that they did here was that they took an elderly population, but it was surgical patients, so that they could measure their pre-ICU disability. And what they did was they measured pre-ICU disability, and then they had a cohort who wasn't hospitalised, a cohort who was hospitalised, and a cohort who received mechanical ventilation. And you can see on the top slide that the activities of daily living didn't change much at all pre and post. This is 12 months for elderly people without hospitalisation. If you were hospitalised without mechanical ventilation, your activities of daily living decreased, or, you know, the points that you scored for being unable to do them increased a bit. But if you were hospitalised with mechanical ventilation, there was a significant reduction in your disabilities activities of daily living. You can sort of see that seems counterintuitive, but that was an increase in disability, and also that your mobility was affected. And they went on to interview the survivors, and the elderly patients said that they might not have chosen to have this intervention if they knew what the outcome was going to be. And the staff and the family both said that the outcomes were worse than they expected after the surgery. So this sort of major surgery is potentially something that could be avoided because patients wouldn't want it. So I think that made me start to think about how do we inform our patients and what do we know about their baseline measures of function. Jack I. Washner published this great paper again a while ago, 9 years ago, looking at the trajectory of recovery, and he described 3 trajectories. One was the big hit, and that would be what you would imagine with most people in ICU who are relatively well. You know, they're traveling along some degree, some pathway, they get a sudden critical illness, and then they bounce back towards normal, and they might never quite get back to normal, but they nearly get back to normal. Then there's the slow burn, the patients who are traveling along, they get a critical illness, and then they just continue to slowly deteriorate, and they have a really poor long-term trajectory. And that's the sort of thing that you might see in somebody, for example, who's diagnosed with cancer or who has some sort of degenerative disorder that they just keep getting ill. And then there's the relapsing recurrence, and they're patients who get critically ill and then they get better, but then they get seriously or critically ill again, and they keep coming back. They bounce either back into ICU or they bounce back into hospital with sort of relapsing recurrences. And I do think that these are really different trajectories, and I'm going to show you how we've tried to look at that in some of our work. And then we know that there are many factors that affect functional recovery, and these include your pre-morbid health, your functional ability at, while you're sick, so whether you're immobilized, how affected you are by drugs, by sepsis, by ventilation, patient characteristics, not just your age and your severity of illness, but how deconditioned you become quickly, the degree of inflammation you have, whether you're delirious, and other things that might, your nutrition, things that might affect your recovery. And then there's interventions that we might deliver, which will vary according to the timing, the dosage, the type of intervention, and the progression of the intervention, whether you continue it just for a short period of time, like in ICU, or whether you carry it on out to the wards, as we're starting to think we should with a lot of our interventions. And then how you measure it, which of course is another can of worms. So we wanted to think about identifying in Australia who was at risk, and we didn't feel that we'd done this well before, because most of our clinical trials group studies really had just had a primary endpoint of mortality, and there was very few long-term outcomes being measured, when I started my career in the ANZIC RC 10 years ago. So the first paper that we published on this was NHMRC funded, and it was in 2017. And we had looked at a cohort of 262 patients across Victoria from ICU who'd been mechanically ventilated for at least 24 hours. And we just looked at the level of disability. And we found that 25% of them at 6 months had moderate to severe disability. But this study was really limited because we didn't know their baseline function, and we hadn't looked at trajectory, how they recovered, beyond 6 months or before 6 months. So there was a lot of criticism from the trials group and some feedback and things to take on board and think about. So we did that. We took on board some of the feedback and we sought out more funding. And we started this new NHMRC funded study, which was the Predictors of Death and New Disability After Critical Illness, a multi-centre prospective cohort study. And we aim to determine the prevalence and predictors of death or new disability following critical illness. And new disability was really important. This was a whole study in itself where we validated the World Health Organization's disability assessment schedule, which is an outcome measure that we'd previously used. It looks at measures of function, including physical function, psychological function, and cognitive function. But it's a really simple tool, and we used the 12 levels, so it's quite quick and easy. But we validated it, showing that a minimum clinically important difference would be a 10% change from baseline. So we did a prospective multi-centre cohort study in 6 centres. The participants were adults admitted to ICU, again, ventilated for more than 24 hours, so similar to our previous study. But the new primary outcome was death or new disability, where we described this new disability as the minimum clinically important difference, which was a 10% increase in the HUDAS. So we actually included 628 patients with the primary outcome. The median age was 62 years, and 379 had a medical admission. And 370, or nearly 60% of those patients, died or developed a new disability by 6 months. So this is really the first time we've been able to quantify death and new disability. And when you looked at the trajectory of recovery, you can see that there was a real difference. And that is people who had, so a higher HUDAS is worse functioning, so that's increased disability. So you can see these people who were separated with a worse disability at baseline continued at 3 and 6 months into a trajectory of worsening disability, whereas people who had a slightly lower disability at baseline seemed to improve. And this is now the alluvial plot where you can actually, so what we did is we actually worked backwards. So we separated patients who had moderate or severe disability at 6 months and people who had no or mild disability at 6 months. And then we worked backwards, and you can see the grey and the pink to see where they started. So there are certainly some people with moderate and severe disability who had none at the beginning. There's very few who have moderate to severe disability, though, who had no disability. Only a few had no disability at the start. And a lot of them had some degree of disability before they started. So at 6 months, 27% of the surviving patients had less disability, 34% had the same level of disability, and 38% developed new disability compared to baseline. So if you think back to Jack's trajectory of recovery, you can think, that some of them improved and some of them continued about the same, and some of them significantly deteriorated. I just think that this is ongoing work that we're going to need to do to separate out why. And it certainly seems that we could predict some of these people. So the independent predictors of death or new disability were older age, higher severity of illness, and an admission diagnosis that had higher odds of death. And of course, none of you will be surprised to see cardiac arrest, sepsis, and trauma in there. But unfortunately, none of these are modifiable risk factors. That's a pity, because we did look at a whole lot of in-intensive care factors that might have been able to modify death or new disability, and none of them were. There was just non-modifiable factors. So the conclusion of this first study was just that less than 50% of patients who were mechanically ventilated for more than 24 hours were alive and free of new disability at 6 months. And a model including age, illness severity, and admission diagnosis had an acceptable discriminative ability to predict our primary outcome at 6 months. So then that led to a study where we used the same data to look at post-sepsis syndrome. So just moving on to look at how that might look if we want to try and predict whether sepsis has an impact on 6-month outcomes. So we know from the work from Hallie Prescott and Jackie Washner and others that there are 19 million individuals who develop sepsis per year, and that a third of them die and 1/6 of them remain impaired. And the new impairments are 1 to 2 new functional limitations, a 3-fold increase in cognitive impairment, and other factors. And then we have this work from Callie Thompson from the George Institute, where they looked at critically ill patients who are enrolled in the CHEST randomized controlled trial. It was propensity score matched, and they found that there were 806 patients with sepsis at admission compared to 806 patients without sepsis. And there was absolutely no difference in health-related quality of life at 6 months or survival at 2 years when they propensity matched those patients. Sorry, hard to spit out. But what I'm trying to say is that these patients were well matched, and there was no difference in their outcome at 6 months or their survival at 2 years. So then we went on to do a secondary analysis of our prospective cohort study, the data that you've just seen. We again looked at adult patients who were mechanically ventilated for 24 hours. That's who was included, and we used the HUDAS as our primary outcome. We had 218 patients who had sepsis and 454 who didn't have sepsis. And unfortunately, there are really significant baseline differences, which is, again, probably not surprising to the clinicians. And that is that they were admitted from different areas. Their severity of illness was worse. They were more likely to be delirious, the sepsis patients this is. They were more likely to not have a cardiovascular diagnosis. They were more likely to have renal failure in the first 24 hours, and they certainly had longer duration of mechanical ventilation. So we are not really comparing apples with apples, but we did do some adjustment for baseline differences. And we found that 25% of patients died overall, but it was 35% of the patients with sepsis and only 20% of the patients without sepsis. So sepsis definitely, and this is an analysis that was adjusted for age and gender and ICU admission source and severity of illness and type of admission and creatinine, heart rate, other things. So we do think that this is, a significant difference in terms of mortality. However, when we looked at new disability, and this is the graph of the HUDAS at 3 and 6 months, where red is sepsis and blue is no sepsis, you can see that it looks like there was increased disability, but there's certainly a statistically significant difference at 3 months, but not at 6 months. So there were 39, nearly 40% of survivors with sepsis and 35% without sepsis. And you can see that there was no difference in the severity of disability at 6 months in the prevalence of new disability. There was no difference in health-related quality of life. And then we've got some other outcome measures down here, including MOCA blind, which is cognitive function, instrumental activities of daily living, PTSD. It looks like there might be a difference, but there's actually no significant difference there. And anxiety and depression, no difference. So really, no difference between any of our sort of functional outcome measures. It was really just a difference in survivors. But when you looked at the sorts of new disability that occurred, new disability occurred across all levels of functioning. So this is the 12 questions asked in the WHODAS. Its ability to wash, walk, learn a new task, stand, day-to-day work, dealing with other people's dealing with other people, household tasks, maintaining a friendship, and it goes on. And you can see that across all areas, at 3 months and at 6 months, regardless of whether you had sepsis or whether you didn't, you had new disabilities across all areas of functioning. So finally, I wanted to talk briefly in the few minutes I've got left about our latest study, and it was recovery after COVID-19 critical illness. And this is a manuscript that was just published online at Critical Care yesterday with a media rollout across the ABC, in case you caught it on the news last night. This is obviously with COVID-19, it's a wide-ranging disease spectrum, and we know that long COVID looks very like post-intensive care syndrome for all other terms. So we're not really sure whether COVID is any different to post-intensive care syndrome at this point. But what we did do is very similar to what the work we'd done previously. We did a multi-centre registry-embedded prospective cohort study. It was embedded within Sprint-SARI, and most of you would know what that is, but it's the study the registry that's been collecting data across Australia for all our COVID-19 patients admitted to intensive care. And it meant that we could link with Sprint-SARI, and we needed to collect minimal additional information. We could just follow up the patients and link with Sprint-SARI. And we also had the non-COVID-19 patients from our previous study from PREDICT, so that we could compare to the COVID-19 patients. So we aim to do 3 things: to describe new disability, changes in functional outcomes and health-related quality of life in patients with COVID-19, to compare that with critically ill patients without COVID-19, and to do a qualitative study of COVID-19 survivors. And I'm just showing you a little bit of some of these today because of time. But we included 212 patients altogether from last year, 2020. And as you probably know, we had about 500 patients in ICU in 2020. So it was nearly half of the cohort that were considered for inclusion, a relatively younger age, 61, mostly male, and you can see a relatively low severity of illness at 14, but a long length of stay in hospital. So we found that 48% of them or the score of the manual muscle test was 48, so 42% had ICU acquired weakness. The highest level of mobility in ICU was standing. Duration of ventilation was 12 days. Of those, there was only 50% of this cohort who were ever ventilated though, so just bearing that in mind. And the ICU length of stay was 7 days. Now, this was for 2020, so this does not include the Delta variant. But 56% of our cohort had death or new disability at 6 months, so a fairly similar rate compared to the non-COVID cohort. And when we looked at our outcomes, I think you can see this is the WHODAS, and you can see baseline in 6 months, and there was a really significant increase in disability and a decrease in health-related quality of life. And this is because the COVID patients had a much more normal baseline function. So they had a good functioning and a good quality of life prior to their critical illness, which was different to what our previous cohort looked like. So we have differences in baseline functioning and baseline health-related quality of life in the COVID-19 patients compared to non-COVID-19 patients. And we had 71% of patients who were still reporting symptoms at 6 months. 43% of them were reporting 3 or more symptoms, and the most common ones were shortness of breath, loss of strength, and fatigue. And I haven't shown you the comparison data, and that's because it's under review. But essentially, when we've compared COVID and non-COVID, the take-home message is that at 6 months, the amount of disability looks very similar to non-COVID patients. So in summary, in this national cohort of COVID-19 survivors, 20% died and 36% of survivors developed new disability. in survivors, over 1/3 had new disability and 1/3 had increased cognitive dysfunction. There was a significant decrease in health-related quality of life, and that was because their health-related quality of life was so good at baseline. 1/5 reported anxiety, depression, or PTSD, and the majority of the cohort had ongoing symptoms. And predictors of poor outcome was older age, high severity of illness, and increased frailty. So they were all independently associated with death or disability in COVID-19 patients. We have finished the qualitative arm, and that's just been written up. For any of you who saw the news last night, this is Shireen, who's our survivor, who was the star. She had a really traumatic experience, and I've just picked out some of her quotes because she's agreed that I can share them. And this part of the study is being led by Stuart Lane and Christina Whitehead, so just a shout out to them. But, you know, some of the things that were said were things like, my doctor called ahead and said, hey, she's coming. They're like, are you the COVID one? Get out, go to another door, because it was weird. You know, you felt like a leper. So people had really a lot of trouble accessing help when they were sick. And then within 30 minutes, the doctor says, you know, you probably have COVID and you're going to die. So last year, there was a lot of, you know, people who were just being told they weren't going to survive this. And then Shireen went on to say, my husband's still not returned to work. This was at 6 months. My husband's still not returned to work. He's still suffering from PTSD when the phone rings, because I used to call him at night to tell him, you know, she's probably going to die within the next hour. So when he hears the phone ring, it scares him. Just to add to that, Shireen's daughter's gone on to have significant mental health issues and has had to be admitted for psychiatric care just because she thought she was going to lose her mum last year. And she was at the age where she was being a wicked witch to her mum before her mum was admitted to ICU. And the last thing she remembers is being horrible to her mum before she got sick. So, not to add on a negative note, I just wanted to say that, you know, we're not just, the reason why I got interested in long-term outcomes is because we were doing clinical trials that were testing interventions that were trying to improve survival. And now we're testing early interventions to try and improve recovery. And I'm really proud to talk to some of the trials that I'm involved with. And, you know, I've just put 4 up, and there's many more. I know Emma's on the line, and she's running the nutrition program with some great trials there that are looking at longer than the ICU stay and looking at some functional recovery as well. But these are trials that now have not just mortality as a primary endpoint, but, you know, morbidity. So Bone Zone looking at prevention of bone loss, particularly in, that's not meant to say in the elderly, that's meant to say in women of menopausal age. TAME that has looked at, again, sorry, you can see I've cut and pasted this slide, TAME, which is looking at CO2 targets in cardiac arrest, TEAM, which is looking at early mobilisation, and Megarox and Logical, which are looking at oxygen targets. And Logical, TEAM, TAME and Bone Zone all have primary outcomes at 6 months, including functional recovery. So just to finish up, I just want to say critically ill patients have new disability. It seems to be regardless of what type of critical illness across the board, we're looking at significant new disability. It's common in all areas of functioning, physical, psychological and cognitive. And we really do need to work hard at strategies to reduce disability, and that's within our clinical trials, to improve the transitions of care as they move out of ICU and back home from hospital, and to look at improving quality of life across all critically ill patients. Just wanted to say a huge thank you to particularly the sites that participated in COVID recovery, because that study pivoted last year during the pandemic when the clinicians were at their most stressed and busiest, and I'm very grateful to everybody's help with that study, and collaboration is everything. So if there's one thing we know as female clinicians and researchers is that we, you know, it takes a village, and I think that we created that ourselves. Thank you, everybody.
Thanks so much, Carol. That was a really interesting talk as well. I just want to open up the chat group again to any questions for Professor Hodgson.
And I won't be offended at all if the questions are back to Imogen, because I think that was a really fascinating discussion that we were having. Imogen, maybe I'll ask you a question while we're waiting, and that is, you know, how do you see the role of mentorship in all of this? Do you think that there's an important role for female intensivists to be mentored into, you know, fellowship positions or even into academic positions?
I mean, I was just trying to think back, who inspired me and why I did intensive care. I mean, I suppose because, this was in the dark ages, there were probably very, very few women. And so like you, I've, been inspired by men, and, they've supported me. But there have been times when I haven't felt they would know what to do in a sort of more social situation, and how did they manage, their mat leave or whatever. So I think there's a time and a place. And, I think all of us would see that it's not just one mentor, it's sort of multiple mentors that you go to for different reasons. So I do think having more women in the workplace, in a particularly medical way, is probably advantageous, and that, they can also help you understand it is possible. But I think, again, when I came through, there was just, the hours were ridiculous, and I don't think one should expect that anymore. And I think, we do need to be more flexible in being flexible. I think, we're just, like as Sandra said at the beginning, the leakage to anaesthetics, why is that? So I think, and I certainly think that it is helpful to have mentorship. I'm going to ask you a question now, Carol, because Carol, it was a great talk, as always. But as I keep saying to Bernie Bissett here in Canberra, as you know, who's quite passionate about, rehabilitation pathways for intensive care, to me, COVID is actually quite helpful for us in terms of helping people understand this is a thing. This is, when you put patients into intensive care, the knock-on effect is significant. And it's not just COVID. It is, every sort of disease entity that requires mechanical ventilation and, significant support means that there are going to be downstream consequences. So in some respects, I sort of feel it's obviously not very helpful for people having the COVID, but it actually does highlight not only intensive care, because now not being confused with emergency medicine, which is good. And the other thing is, this is the problem, and we really need to do something about it. I'm curious as to what you think.
Yeah, I completely agree, Imogen. I mean, there's nothing like a pandemic where everybody's been admitted to intensive care to highlight the importance of critical illness and the funding that might be required on the knock-on effect after critical illness. So, I think that, if there's a silver lining to, what's been a really tough couple of years for all of us, it would be that. And it's interesting because, yesterday, after there was quite a bit of media about the COVID recovery paper, I had a lot of emails from people who had swine flu a decade ago and who had other illnesses, and they said that, their illness and their problems after critical illness all looked exactly the same as, what we're now calling post-COVID syndrome. Most people call it long COVID, but the correct term apparently now is post-COVID syndrome. So I do think post-intensive care syndrome and post-COVID syndrome are going to look very, very similar long term. Now, there might be some unique differences because it does appear that there's, microvascular damage, in the brain, in the lungs, in the kidneys and whatnot, and that might be different to some other disorders, but we don't know that for sure yet either. So, I don't know how else to answer that, Imogen, other than to say that I think there's a huge amount of work to be done. It would be great if there's some funding. Somebody said to me in the chat, will Delta have worse long-term outcomes? And, that's a great question. I just want to put this in perspective, though. We pivoted in a year without any funding to do this study. And, literally I took it out of my own sort of personal bank of money that I've got. It's not really my personal bank of money, but it is my fund for research. And, there was no dedicated funding for it. So we haven't gone on to do a second wave for Delta, but we're going to. So now we just have to try and really pitch hard. So we've got in funding applications. And as you know, they lag 6 and 12 months behind where you need them, particularly during a pandemic. So we've applied for some funding. We're likely to be unsuccessful, knowing the way that the rounds are going at the moment. And Ronaldo and I have hatched a plan to try and, get some data for at least for the Victorian survivors. And I know John Fraser's group in Queensland are also looking at long-term outcomes after COVID as well, but they're also short on funding. But they've got some international sites which have some funding, so that's terrific. Yeah, other than that, all I can say is, there's such a lot of work and there's so much more that we need to learn. And I've really just scratched the surface. I mean, what we've done is telephone interviews. It's not enough. The in-person follow-up is incredibly important, but it's expensive and most patients don't want to come back into the hospital. Who can blame them? But yeah, there's just so much more that needs.
And I think the other thing, and I know there's another question for you, is that I'm certainly looking at the whole cohort of COVID. Up to 10 to 15% don't have mobile phones, 40% don't have GPs, and we are really looking at a vulnerable group. And it'd be interesting to see how your data reflects that, or is in fact you're now, actually got a skewed population because they're the ones that you could get in touch with the phones and through GPs or whatever. So it's certainly not an easy area to pick.
Yeah. So Sarah's asked about a multidisciplinary team post-COVID-19 recovery follow-up bundle to address functional, emotional and psychological impacts. Is there a framework from the PICS cohort which is applicable? And, no, there's not. So we don't have, that's not true. In Australia, there's a couple of centres that have follow-up clinics. So, for example, the Nepean has one. It's not been established for a very long time, but they certainly have one. There's a couple that I know are being established. Kimberly Haynes runs not exactly a follow-up clinic, but sort of a follow-up clinic from the Western Hospital. So there are a few that are appearing. Part of the problem is that there's been a lot of research into follow-up clinics, large multi-centre, well-conducted trials, international from several different countries, and they've all failed to show a difference in outcomes. Now, whether they were measuring the wrong thing, they didn't show any improvement in health-related quality of life, and whether they needed to just look at, emotional support, rather than looking at outcome measures, whether they needed to look at sort of, PREMs rather than PROMs. I'm not sure, but there's so little work being done in that space in Australia because it's very hard to get funded because there's no research that shows it's effective. So it makes it really hard. Within the hospital, I think there's certainly a huge amount we can do. And I know that all the hospitals for the COVID-19 have outreach, and that's meant to be multidisciplinary, but I don't think it is particularly, I don't know, I think that varies probably from jurisdiction to jurisdiction and probably from hospital to hospital within the jurisdictions as well. And last but not least, I'd say that I think that there's a huge burden on the GPs. When we've spoken to the survivors, what they've said is that, it's really come down to whether they've had a good GP or not, whether they get tapped into the right resources when they make it, when they're discharged from hospital. And some of them have also commented that they've had a GP for life and they've had to change GPs because they just haven't felt that they were supported the way that they needed to be supported. So just some interesting comments from our survivors. The other thing that the survivors have said is that, at the moment, I think most people are trying to follow them up within a month or so. Some hospitals even say 6 weeks, but the survivors say that's just way too long. If they get discharged home, they need to be seen within, a week or two because they're really struggling to cope once they get home. Do I see the commencement of post-ICU clinics as a regular part of Australian practice? Like I said, I just don't see that we're ever going to get funded for it. I think it would be, I think I don't want to start a service that has no benefit either. So it would be good if we had a study that actually showed benefit, but we have no research that has shown benefit. And so I think it's going to be really hard. It's going to be funded at a hospital level, and it'll be hard to keep it going because the hospitals will have to fight for the funding to keep it going. And also the other thing that I'd say is I've spoken about this a lot within a big multidisciplinary team, which includes cardiologists and respiratory physicians. Some of them are really opposed to an ICU follow-up clinic because they say that once the patient leaves ICU, they become under cardiology or under respiratory medicine or under surgery, and the follow-up should be done by those units which actually continue on with their care, and they don't see that intensive care has a role in the follow-up unless there is really specific issues that are not generalized to those other specialty areas. So particularly the cardiologists see us as really problematic in terms of our involvement after ICU discharge. So just note of caution when you're trying to step on people's toes around follow-up clinics. We've had some pretty heated discussions in some of our management committee meetings about how we manage this. And follow-up clinics would be great for the aging intensivist. I completely agree, Di. die. I think they'd be great for the aging physiotherapist as well, just quietly. All right.
Thank you again to Professor Hodgson and Professor Mitchell for both of you to take all the time that you have today to speak to us. We're really grateful to have you here, and they were really interesting talks. I also want to say thank you to Sandra, Chair of WIN, who's here today, and also Brent from ANZICS, who helped to facilitate this entire webinar. Thank you.
Thanks, Vanessa. Thanks, Sandra. And all the best, Sandra, with the bub.
Yeah, well, congrats. Great. Thank you.